e apresentar todos os speakers, convidados da noite. Eu venho aqui na frente porque vocês precisam saber disso. Eu preciso também dar boa noite para todos que estão nos assistindo através do canal do YouTube, em tempo real, isso vai ficar gravado para depois poder ser compartilhado com muitas pessoas. Então, para você que está em casa, no trânsito, no hospital, e está assistindo, desejo uma ótima noite e uma excelente reunião. Não? Nada pegaram? Captaram o som? Ou não?
Dá para escutar mesmo.
Aqui está dando para escutar, mas o microfone não está. Bom, só repetindo então, boa noite a todos, tá? E estou dando boa noite aqui para todos que estão nos assistindo pelo YouTube e pelos demais canais de transmissão, pelas redes sociais. Agradeço a presença de todos que estão aqui fisicamente e para também quem está em casa, está no carro, está no trânsito ou está no hospital. Eu desejo a todos uma excelente noite e que todos possam aproveitar ao máximo esse evento que reúne experts do mundo inteiro, com um grande destaque para o professor Daniele Rigamonti, doutora Karen também, e o professor Fernando Hakim. Karen, por favor, é com você.
Então, boa noite a todos, bem-vindos ao Hospital Moriah. Meu nome é Karen Gerencer, sou gerente médica aqui do hospital. Queria agradecer a todos os convidados por estarem presentes aqui nesse summit muito especial. Queria agradecer em especial os nossos convidados, nossos palestrantes, que é o Dr. Daniele Rigamonti. O Dr. Daniele Rigamonti, ele é CEO do Johns Hopkins Aramco Healthcare e professor de neurocirurgia da Johns Hopkins University School of Medicine. A doutora Karen Rigamonti, médica especialista em liderança e cultura organizacional, e fundadora da KHDR Consulting. E o Dr. Fernando Hakim, que é chefe do Departamento de Neurocirurgia e diretor do Centro de Hidrocefalia de Pressão Normal da Fundação Santa Fé de Bogotá. Eles são nossos palestrantes convidados para esse evento, que vieram a convite pelo Dr. Fernando Gomes Pinto, neurocirurgião e especialista do nosso Instituto de Hidrocefalia de Pressão Normal, aqui do Hospital Moriah, e professor livre-docente da Universidade, da Faculdade de Medicina da USP. Então, eles vão falar um pouco para a gente sobre a experiência do paciente e a construção de centros avançados em neurologia e neurocirurgia, além de compartilhar um pouquinho com a gente um pouco sobre liderança, segurança e o cuidado humanizado do paciente. Eu queria agradecer, então, a todos e convidar agora o Dr. Pedro Paulo Mariani, nosso neurocirurgião aqui do Hospital Moriah, para falar umas palavrinhas aqui para vocês. Obrigada.
Obrigado. Bom, boa noite a todos. Como neurocirurgião e médico do corpo clínico do Hospital Moriah, queria agradecer a presença de todos vocês aqui essa noite. Eu venho coordenando um grupo multidisciplinar envolvendo neurocirurgiões, endocrinologistas e otorrinolaringologistas desde 2016 no tratamento dos tumores hipofisários e outros tumores da base do crânio. Sob a direção executiva do Dr. Alexandre Teruya, o Hospital Moriah ele sempre preza pela excelência no tratamento e pela inovação. Então, todos os tratamentos específicos, especializados, especialmente os cirúrgicos que realizamos aqui no Hospital Moriah, seguem essas diretrizes. E esse ano, nós tivemos a boa notícia de ter mais um excelente, um significativo apoio aqui com a vinda do Dr. Fernando Gomes e a criação do Instituto de Tratamento da Hidrocefalia de Pressão Normal. Então, eu queria parabenizar o Dr. Fernando e todo o pessoal que organizou esse evento e agradecer mais uma vez a presença de todos vocês aqui. Obrigado.
Agora eu queria convidar o Dr. João Luiz Pinheiro Fran, nosso cirurgião de coluna, também aqui do Hospital Moriah, para também falar umas palavrinhas para a gente. Por favor, doutor.
Boa noite a todos. É um prazer estar aqui. Vou começar falando português primeiro. Parabéns ao Hospital Moriah pela organização, a todos. Muito bacana, uma palavra boa, bacana. Em português, bacana is a very nice word. The hospital is muito bacana. Eu estou muito contente de estar aqui. Fernando, parabéns. Eu conheço o Dr. Fernando há muitos anos. Uma classe, uma elegância, de uma honestidade. Eu tenho uma grande admiração por você sabe disso, né? Good afternoon, ladies and gentlemen. It's a great honor and a personal privilege to introduce Professor Dr. Daniele Rigamonti and Dr. Karen. My first contact with Professor Rigamonti took place 20 years ago, when I had the opportunity to spend a period of fellowship at Johns Hopkins Hospital in Baltimore. At that time, I was just beginning my international academic career, and one particular memory has remained with me ever since. Beyond his extraordinary accomplishment as a neurosurgeon, Professor Rigamonti demonstrated a quality that, in my opinion, distinguishes the finest teachers: generosity. He and his wife, Dr. Karen, welcomed me into their home with remarkable kindness, introduced me to their family, and made a young Brazilian neurosurgeon, I was 33, feeling truly at home. Acts of generosity such as this remain in one's memory for a lifetime. My father, who is also a neurosurgeon, have previously had the opportunity to know Professor Rigamonti professionally. It was therefore a special pleasure for me to meet him personally and to experience the same elegance, kindness, and generosity that had always characterized him. During that period, we spoke about his professional journey. I vividly remember listening as he described the challenges of leaving Italy to build his academic and professional career in the United States. He spoke about the tremendous effort, unwavering dedication to his patients, commitment to study, and relentless work that were required to establish himself at one of the world's most respected medical institutions. That conversation left a lasting impression on me. Over the years, I came to understand that scientific excellence is never the result of talent alone. It is built through discipline, perseverance, intellectual humility, and an enduring commitment to patients. In my own career, I was later fortunate to continue my international training by working for 3 years in France and 2 years in Germany. I later authored the book in Springer in Advanced Concepts in Lumbar Degenerative Disc Disease, and also co-authored the book Sagittal Balance of the Spine in Theme, New York. I have always remained grateful for the opportunities to learn from outstanding physicians and scientists throughout that journey. Today, 2 decades after our first meeting in Baltimore, it's a great pleasure to welcome Professor Rigamonti to São Paulo to share his experience and knowledge with us. Professore Rigamonti, 20 anni fa lei mi ha insegnato con il suo esempio che il talento è importante, ma che sono il lavoro, la perseveranza e la dedizione a costruire una vera carriera. In Brasile diciamo che Ayrton Senna ci ha insegnato questo nello sport. Per me il suo esempio lo ha dimostrato nella medicina. Grazie. Professore Rigamonti and Dr. Karen Rigamonti, it's a true pleasure and honor to welcome you both. Thank you very much for accepting the invitation and for being with us today. Ladies and gentlemen, please join me in welcoming Professor Dr. Daniele Rigamonti and Dr. Karen Rigamonti.
Remember meeting my daughter? It's now a neurosurgeon. Just as you.
Wonderful.
I don't know.
apologize in advance if the technology is overwhelming. In 2014, I was asked by the president of Johns Hopkins International to consider transferring with my wife to Saudi Arabia to stabilize an important initiative of the university. Saudi Aramco, which is the largest energy company in the world, had decided to transfer the medical division into a partnership with Hopkins. And that created a lot of tension because the people working in Aramco Medical Services were actually benefiting from a very generous package from Aramco. And they were very anxious about coming over to Chaha. When we arrived, we saw, therefore, a lot of operational challenges, but also a low morale, and the patient actually felt that. Shortly after we arrived, the CEO decided to transfer out of the company. And so the Aramco leadership asked me to consider becoming the CEO. After a few, after a few months, I felt like I was drinking from a fire hose because the responsibility suddenly became very numerous and somehow overwhelming. And that is when Karen came actually to my help.
As a culture development specialist, I coached him and reminded him to focus on a few things. One, sending a clear, constant message to the staff. Two, keeping an open door policy to inspire trust and psychological safety for everyone. And three, expect that achievement of collective capabilities only happens when you hold people accountable and recognize the role of systems in the genesis of errors.
So we decided to make the mission for the company something very simple. I told the staff and everybody involved that we were going to improve the quality of the healthcare that we provided. And it's a quality, according to the Institute of Medicine, is consisting of safety, timeliness, efficacy, efficiency, equity, and patient-centered care. But I wanted to make sure that everybody knew, not just the doctor or the nurses. So I asked the chef of the company to create a cake with the element of care on the top of it. We made hundreds of them, and we distributed in the operating room, in the clinic, in the offices, everywhere, so that everybody could read them, eat them, and hopefully digest also not only the sugar, but also the content involved with it.
And understand that the quality is what we really wanted to convey. So to carry out this mission, we began dealing with the low morale and the low engagement of the staff. And the reality is that low engagement is really a safety issue. When people are disengaged, they don't speak up. And when they don't speak up, the risk increases. So low engagement also is a financial issue because by increasing turnover and decreasing efficiency, low engagement raises costs. And finally, low engagement is a real leadership issue because leaders determine whether engagement corrodes or grows based on what they do every day in front of people, what they create, what they tolerate, how they are with their staff, and what they're modeling. So instead of starting with policies, we started with people. When I asked the staff what is your biggest pain point? Surprisingly, they told me, patients are just too demanding. They're really difficult. And if it's not the patient, then it's the family. So have you ever felt that way? That sometimes I see some heads nodding. Yeah, we're all noticing sometimes they just feel like an inconvenience. They get in your way. Well, we discovered through interactive experiential training that, that had a greater than 90% approval rate by the staff taking these experiences, that they not only approved of it, that the patients were not really the problem. They realized that communication was the problem, their communication to the patient and the patient or family's communication back. And that's where the problem really started to surface. So the next pain difficulty was, believe it or not, they said, we have the same problem with our colleagues. And have anybody felt that way? Raise your hand if you know some colleague in your system that's been challenging. Most of us do. We may not admit it. Sometimes we even think our family can be challenging. So again, with experiential training, we helped the staff to learn that there was a personality, you know, what they thought was a personality problem wasn't really a personality problem. It became a trust problem, that we don't necessarily trust everyone, that they don't do the things that, and follow what they say so that you have confidence in them and what they're going to do. So the perception of difficult colleagues takes different forms. For example, a person might be walking down the hall and having a bad day, and they don't nod at you or say hello, and you kind of get insulted and think, what's wrong with them? They don't like me anymore, and then you react, and everyone keeps reacting. And there's other examples, you know, like in emergency rooms, they call for a consult. You don't show up fast enough, and then they're annoyed with you because nobody has communicated that trust. We really want to be there. I'm just finishing up with the patient or something of that sort. And telling them so that they understand when you can show up and when it's okay that you're delayed. Or they want the patient out of the emergency room onto the floor, and they're mad because the people on the floor, the nurses aren't clearing the beds fast enough. And the reason they're not clearing the beds fast enough is because you can't get a bed free until you get a patient out. Everything takes time. So there'd be much less frustration and better perceptions if everyone took the time to explain, we want to be there as fast as we can, we're doing everything we can. And so you can avoid so many issues when you just let people know what the situation is and that you're working to try to help them.
So it is actually proven in the literature that, for example, the perspective regarding conflict varies depending who you are. For example, in the operating room, 60, 69, 70% of the surgeons think that if there is a conflict, it has been resolved, while the anesthesiologists feel like 55% of the time it is resolved. And when you ask the nurse, is the conflict resolved? The nurse thinks that that is the case in less than half of the time, 47%. And in the ICU, when you ask the doctor, is this a place where you have a good relationship with the nurses? The doctor will say 73% of the time is a very good relationship. When you ask the nurses, that they say is a good relationship only 33% of the time. So how do we get the system to change? Because obviously this is more than a personality problem, it's a system problem.
So we focused on something that's often underestimated, and that's compassionate communication. Because research shows that compassion is needed, and it's just as needed as technical skills are. So you may be great at what you're doing clinically, but without that compassionate communication, it doesn't land. And compassion has a lot of benefits. It benefits the patients and the families by reassuring them. It helps protect the staff from burnout, which has become a very big problem worldwide, and it helps to lower the risk of harm for errors, because when patients and staff feel that they're heard, they are much more likely to share information fully, and when you share information and it flows, then the risk goes down. Then we went to the senior managers and started coaching them, because again, they're critically important for the long-term success of what you do every day. So their words and deeds are greatly followed by everyone, and they're perceived as following organizational values or not, depending on what they do. And the staff want to know that they're going to be rewarded for what they're asked to do, and not be asked to do something and have something else be modeled in front of them. So a strong manager leads a cohesive team with members that trust each other, they speak up, and they commit decisions and plans of actions. And they hold each other accountable for delivering those plans expediently, but still effectively, because fast without being effective doesn't serve anyone. And so some examples of this is, there was an extremely competent hospitalist. Everyone thought so. I gave a 360 assessment. He had a perfect score. That's like incredible, right? Nobody thought he wasn't 100% perfect, except him. And so I had to coach him to help him understand that if he kept holding himself accountable for not being good enough, he was going to burn out. He just couldn't last like that. Eventually it was going to catch up to him. And so we worked on that, and he really could finally understand that. Then there was a technically superior orthopedist. And the problem was that in the Press-Ganey surveys each year, his team kept falling in the lower end of engagement. He could not understand. He said, I ask them questions all the time. How is this possible? And then when we did some coaching together, we realized he was asking them and then just making the decision for everybody, instead of asking them and let them arrive at the same decision he would, but where they felt that they were actually heard and listened to and appreciated, and not having their time wasted. And finally, a third example would be, there was the head of the Department of OBGYN, and I started coaching him because everyone in his department was upset with him. They didn't like how he, held them accountable. He felt like he had favoritism, all sorts of things they didn't like. And I worked with him and discovered that he was not coachable. He didn't want to change. He would not accept that everyone else might be right and he could be wrong at some time. And so I said, for him, I had to advise the CEO and the C-suite, he needs to be changed. He can, continue to be a great OBGYN doctor, but he can't head a department because he's not willing to be a good leader. And that's the only way that coaching can really be effective. Next, I went to the C-suite because it's the same issue there. They are really important critically to actually get trust within the entire organization and allow people to open up to one another and speak freely without worrying about retaliation and have productive debates. So I stress the fact that even if you agree, but it's not full agreement, you can agree not to agree, but you've got to be able to trust each other that you're safe to speak up and give your thoughts in the right way. And of course, tactfully and respectfully. So, we did that. And when I was talking with one of the chief nursing people, she said, I do those kind of things. And I get out of the office and I go down to my people and I talk to them all the time. And every time I talk to them, I get told everything's fine. Everything's good. And they don't give me anything meaningful that I can work on. And I said, well, maybe in your case, it's not being more visible. Maybe it's asking the right questions. So let's play with that. And when we go down, I'll go down on rounds with you. And I'll just signal you if you start to revert back to your old ways, because you haven't done it enough to really have a new habit yet. Because that unfortunately takes a little bit of time, like going to the gym. You have to practice and practice. So we went down and she started to go back to her old question, and I gave her a signal, and she changed it, and she said, so tell me, what was the most challenging thing you had to do in the last 24 hours that was frustrating? And suddenly it was like Pandora's box opened, and everybody was telling her things, and she got 3 really impactful things. And she took care of them, 2 of them immediately by a phone call while she was still on the ward, making them feel like they really had given valuable information and were appreciated for what they were sharing, and that they could make a change. And the third one was something that took a little more time, and she said, I have to tell you, this one's going to take a little more time, but I will get back to you and keep you posted until we resolve this. And so she turned to me and said, how did that happen? I said, all it took was asking the right questions at the right time to the right people to get the right responses. And it's really just not so hard. You just need to practice. And, you know, that's what coaching and consulting can do for you, is to, like, get you there faster. So she actually was very pleased with that. And then what the other thing we did was we did C-suite executive rounds, and we would match clinical and unclinical. We went too far, so we're not there yet. We matched up a clinical person with a non-clinical person from the C-suite, including the CEO, and they went day and evening shifts to hit every single person in the hospital. And what they did was they went around in front of them and they started asking them and taking notes. And we kept notes, and every town hall meeting, they would go back to the people and tell them, here's what we've been working on, here's what we're not able to address right now, but we will get to it. And they took care of every single issue that came up, so that now suddenly staff had a voice. They had a voice to the C-suite. They felt like they really could be heard. They were able to trust the C-suite that whatever they said, there was going to be an action taken, or they would get a good explanation why it wasn't going to be able to be something that would be installed now, but we would hold on to it for the future.
Regarding the safety, we had a problem because since the publication of 2R is human in 1999, many of the introduction of the safety tools, like, for example, checklist, structured communication, standardized process, were occurring, but the harm continued to occur. For example, we know that in upstate New York, 10% of the patients leaving the hospital have subjected to some degree of preventable harm. And when you look at the Joint Commission, it appears that the number of self-reported sentinel events are not decreasing. As a matter of fact, they seem to be increasing. Next. This graph from a publication done last year shows that in the last 3 years, the number of sentinel events is actually increasing. So we have to ask, we are doing all the right thing. Why is this happening? Why are patients still harmed?
So error is human, as we all know, unfortunately. But the data show that poor communication is the leading cause of harmful errors in healthcare. So when you think about it, it isn't necessarily that we actually make a mistake technically. Again, we're going back to it's the communication that messes us up every time, in the operating room, on the wards, with the patients, and that's the biggest issue. And the quality degrades in that area if staff feel that their voice doesn't matter. And it also degrades if they feel like all their efforts aren't being recognized. And they don't feel safe when speaking up, or that when they do, there's no one that's listening and giving it meaning. So those are the issues that become really challenging. So the main reason that patients continue to be harmed is because safety is not just a technical issue. It's a team responsibility, and it's a social, cultural challenge for everyone. And safety depends on whether people are willing to speak up and whether the system responds to them.
So this is what happened when people don't listen. A young boy was in the operating room to change the dressing due to a bad burn. And the nurse realized that the blood pressure was going down and the heart rate was slowing down. And she told the doctor, who ignored her. This continued for a few minutes, and when the boy reached the recovery room, he was basically right hemiplegic and aphasic.
So this tragedy occurred not because lack of expertise, as we said, but because of lack of protocols. It occurred, or lack of protocols. It occurred because in a critical moment, someone did speak up and someone did not listen, and the system didn't catch it. So when hierarchy silences the team, it becomes a very big issue. And it's the organizational culture that determines the quality of communication and if others are willing to hear you and respond. So the data confirm the need for flexibility. Low mortality hospitals are not better at preventing errors. They are better at recognizing them early and taking action to stop anything that's going wrong and rescue through collaboration. And that's key. And they, in that respect, they behave exactly like high reliability organizations, demonstrating greater resilience. So when a mistake causes preventable harm, it's critical to take responsibility because transparency is necessary to educate the entire staff and so that everyone can learn from the mistake, because what happened in your department, something very similar is likely to happen somewhere else if everyone doesn't learn from it. So safety is a matter of character. What happened next defines the culture of the organization.
I, as the CEO, met with the family and took full responsibility. I express sincere regret, thinking from my own personal experience. I offer to provide lifeline care to the child. I pledge to implement changes to prevent this from happening again, and to provide feedback of effective corrective action. And at the end, I ask for forgiveness. Over the 5 years, we saw an increase in engagement yearly, and this was monitored by Preskeni. Turnover dropped from high to low single digit, and people from Saudi Aramco Medical Services transferred to become employee of JAHA at a much faster rate, and this became a badge of honor. Learning opportunity grew. The residency program starting in family medicine became the top-rated program in Saudi Arabia in less than 2 years. Safety improved. Sentinel events remained very few. Infection improved. The central line acquired bloodstream infection. The catheter acquired urinary tract infection, and surgical site infection remain well below benchmark. Next. Timeline dramatically improved, and you could see a specialty clinic in a matter of a few days from a few weeks. That improvement occurred also in imaging, advanced MRI that would take several months to be scheduled for an elective surgery. Elective case became available in a couple of weeks, and so was the case for CT scan and for ultrasound. Next.
The enhancement of the inter-service collaboration increased the quality of care. The inclusion of patients and families in councils also improved patients' experiences.
Hopkins measured the satisfaction using something that Aramco had adopted for many years, the happiness index, to monitor the services within the entire company. And the happiness index improved yearly for the 5 years that we were there.
And there was the creation of institutes such as oncological, cardiological, neurological, and mother and child institutes that enhance the quality and the efficiency of the care, leading to more collaboration and better selections and better outcomes for patients. And this strengthened also happened in primary care and home care, where the increased patient compliance occurred because of that, and treatment recommendations and reduced readmissions happened when you did that. And the inclusion of contractors in discussions improved the quality of care because they were able to add examples like when there were increased falls on the orthopedic floor, they made a task force to find out what was going on, and they were all set to, and two of the people on the task force were talking in the hall how they were about to order new tiles and all sorts of research on why people were suddenly falling. And the janitor was walking by and overheard them and said, "Are you asking why people are falling?" And they said, "Yes." He goes, "Well, I know the answer," but nobody had included him in the task force. And all he said was, "It's very simple. You don't have to order anything. You just have to change one rule here. You have children that are coming and they're spilling their drinks on the floor and people are slipping. All you have to do is keep the drinks in the waiting room and everything will be easy." And that's what happened, and the rate of falls went down. So sometimes the answer is right in front of you if we remember to ask everyone on the team. Then there was also the Tawazan Diabetes Prevention Program, and it was by changing the lifestyle that type 2 diabetics actually improved and did not go on to require insulin and other things or greater medications. Then there was also the We Can initiative, which was developed as a vocational training for young adults who were severely disabled intellectually. And they were trained so that either they could have some kind of reason for getting up every day, like you or me, and go out into the hospital and do something with someone helping them or independently, depending on their level. And finally, the organization got gold stars and certification for person-centered care by a recognized company globally. And they also got recognized as a disability-friendly organization by the Labor Department in Saudi Arabia that went across all disciplines, not just healthcare.
We perform regularly drills to be able to deal with emergencies of any type, like flood, fire, bombing. And in November 2019, the drill on emerging infectious diseases allowed us to correct the deficiencies. Number of ICU beds, respirators, negative pressure rooms, PPE. We fixed all of that. And when a few months later, COVID started, we were actually the best prepared hospital on the planet. Healthcare costs in Saudi Arabia were increasing at 7% annually. We had a budget of $2 billion, and every year we save 1.5% gradually, yearly for 5 years. After changes, you would say, I can say, you were basically having better service at a lower cost, and I imagine everybody in this room would like to do that.
So we didn't become safer, more timely, more effective, more efficient, and more person-centered because we improved our policies. What we did was we put policies aside and took care of our people.
We had a simple mission, improve quality. We wanted to, everybody in the C-suite down to the front line accepted this goal and the measurement and use it as a base to make decision every day. We made sure that trust made people feel psychologically safe and allow them to speak up if there's any concern. And this produce a very worthwhile debate and basically teamwork and collective collaboration, and this produce collaboration in the C-suite, in the department, in the front line.
So if any of you have any questions, we'd be happy to answer them, and eager to help anyone who wants to have similar goals by sharing our knowledge with you. And please be sure and email us and let us know if you have any questions. We'd love to hear from you, or if something comes up later on, we'd welcome hearing from all of you. Thank you, obrigado, for being a great audience.
Alguém tem alguma pergunta para o doutor e para a doutora agora? No. So thank you for this wonderful and rich presentation. I would like to invite now Dr. Fernando Hakim for his presentation, so please.
After hearing this talk, it's like an introduction to what I'm going to say. Because when you organize a group of doctors, a group of nurses to treat a certain disease, the only person that's going to be beneficiary is our patients. So what I'm going to say now in this talk is how a group of doctors, physiotherapists, nurses, neuropsychologists, neurosurgeons get together to look and find if a patient has certain disease. If it does, treat it, and the results are absolutely excellent if you have a special way to do things, as they just showed us. It's very important to be organized when you treat some diseases. Listo. So, I usually give the talks standing, not sitting. No, está bien, yo me voy a sentar. I have no disclosures, no funding. This presentation was not done with artificial intelligence, absolutely nothing. This is a disease that's called normal pressure hydrocephalus or Hakim syndrome. I am going to put the first picture is a movie to give you an idea, because many people here are not doctors, probably. I don't know who's sitting here, but I want to show you, even the doctors don't know the disease, so I want to show you what this disease is. It's a very small and short video, but you will understand. This was an ad, a propaganda that was done by a company to bring patients with the disease, but it's very nice and very... So,
I'm Bob Fowler, but this was me a couple of years ago. As you can see, I wasn't well, could hardly walk, could barely make it to the bathroom in time. kept forgetting things. There was talk of Alzheimer's or Parkinson's, but what I really had was a neurological condition known as NPH. Normal pressure hydrocephalus. Then I found out that NPH can be treated.
About 1 in 200 people over the age of 55 has NPH. If you think you may have NPH, ask your doctor about a CT scan or an MRI, or call 1-888-LIFE-NPH to learn more about treatment options from Codman, a Johnson & Johnson company.
That was me then. I was treated, and this is me now.
Don't lose your life to NPH. Call 1-888-LIFE-NPH. Codman Insured Life Incorporated, a Johnson & Johnson company.
So you saw this is a disease that in half an hour that after we finish the talk, you will understand it very well. And you will, it's one of the diseases in neurosurgery that is, has treatment, full treatment, if it's well diagnosed, and you can help a lot of patients. And the sad thing is that around the world, there's a lot of people with this disease that haven't been diagnosed. And I am going to begin showing you this. You know what that is? Melancia? Melancia. It's a watermelon or a patilla in Spanish, or sandía. But that sandía has hydrocephalus. If you can see in the middle, the ventricles are big. And I'm going to tell you the story because my father was a very curious person, and one day my mother came from the grocery and put the melancia on top of the microwave oven, and she left it there. And 2 days later, she opened it, and when she cut it to give it to us for lunch, my father said, wow, it has hydrocephalus. So he took the picture, and this is the picture he took. So it's funny to see that many fruits, animals can have hydrocephalus. That's just the beginning. Look at this picture. We did it yesterday. In this moment, we looked at all the statistics. There are around 32 million people worldwide estimated that have the Hakim syndrome or normal pressure hydrocephalus. And in the world, everybody knows what's breast cancer. There's only 8.2 million of women that have cancer. So look at the difference. It's a big difference, and it hasn't been diagnosed. There's a lot of ads about breast cancer, but there's not a lot of ads about normal pressure hydrocephalus. So the only way that we can recognize this disease is by telling you what it is and ask questions. And another thing I have to say, when we get patients, usually the patients don't come because the doctor, neurologist says, go see the neurosurgeon, or a doctor tells her, go see the neurosurgeon or the neurologist because you have MPH. Usually the people who send us the patients are ordinary people that diagnose the disease because it's very easy to diagnose when you see how the patient walks. When you know something, you can diagnose it. If you don't know it, you won't be able to diagnose it. This is 1964, when my father, Dr. Salman Hakim, describes the disease. This is one of the first patients he had. Look at the way he walked. It has three things, this disease: gait, the way they walk, cognitive decline, dementia, and urinary incontinence. But the most important thing is the way they walk. It's the first symptom that you can see, the first sign. Look how the patient walks. It's a magnetic gait. Imagine that your shoes are metal, and in the floor you have magnets. It's hard to elevate the feet from the floor, so it's like a magnet. Look at this. Look how he walks. And another thing is, when you tell him to turn, he turns only in one foot. It's like a compass. That's typical of this disease. If you learn that, you will diagnose it immediately when you go out of the door. You see how they walk? That's magnetic gait, okay? It's described and published in the Journal of New England Journal of Medicine in July of 1965. And just keep this in mind. In the introduction of the article, it says, an opportunity for rescuing from oblivion. Oblivion is el olvido. At least some of these patients who, inasmuch as the syndrome has not been recognized previously and have been diagnosed as a hopeless case. And what they really had, they think you have Alzheimer's, and what you really have is normal pressure hydrocephalus. Described in 1964 by Dr. Salomon Hakim. It says Adams at the beginning. I'll tell you the story. It's what really happened. Dr. Adams was a very important neurologist in the Massachusetts General Hospital in Boston. He was the teacher of my father. When my father gave him the paper to revise it, he looked at it, and the only thing he changed was the order of the authors. He put Adams first. And my father said, why did you put Adams first? If I described it, I wrote it. He said, because here in the United States, we publish and we put the order of the authors in alphabetical order, and A comes before the H, which wasn't true, and finally it was changed. And if you see there, I am very glad to say that when I went to Boston, I met Dr. Adams, I met Dr. Fisher. Well, I met my father, obviously. Dr. Ojeman and Dr. Sweet. All of the persons that neurosurgeons and neurologists that are in that article, I met them, and I feel very fortunate to have been done, because as a neurosurgeon, everybody knows that the Fisher scale and Dr. Adams and whatever, so it's nice to have met them. Look at this is the same. This is a patient which doesn't even have a gait. He doesn't even walk. Look 2 weeks after, when he was shunted, and look 3 weeks after. Look at the difference. And obviously he was demented and he was incontinent. So look how you can help a patient. There are not many things in medicine that you can do such a good job. Through the years, in 1964, there's my father, Dr. Salomon Hakim, describes a normal pressure hydrocephalus. Then in 1983, the hospital where we work was created. And I have to say, I always say, it's not because Dr. Rigamonti is here. It's actually one of the first times or second time that I give this talk, having Dr. Rigamonti in front of me and his family, which I feel very proud. I had the opportunity to go in 2013 to Baltimore, because I saw one time that Dr. Rigamonti had a hydrocephalus clinic. So I told the director of my hospital that we had a joint venture with the Johns Hopkins when he went there to go and speak to Dr. Rigamonti. So he went, Dr. Rigamonti, tell me if this is not true. He tells me he comes into the office of Dr. Rigamonti and says, I come from Bogota, Colombia, and Dr. Rigamonti says, I know Colombia. That's where the Hakim are. That's what he told our director of the hospital. So a couple of months later, the hospital took me to see Dr. Rigamonti, and I spent a couple of days there and went into the OR with him, and he taught me many things. And then we began to work on our hydrocephalus clinic. I learned some tips, and then by ourselves we did different things. But that was the first motor that I had, because when you go to such an important hospital with such important people and show you what they are doing, you can also do it. Sometimes the people in Latin America, I don't know why, but they used to think that we can't do things because we're from Latin America, which I've never believed that. And I know Fernando Gomez would never believe it. You can see what he's done. There are different types of people in the world, and some people do things, some others don't. When I was, first time they called me as I'm the chief of neurosurgery of the hospital, I told the residents, you are able to do whatever you want. And we are here in Latin America, but we can do big things. And now that here they're sitting with me, they know that what I said is true. So always believe in yourself. Okay, so afterwards then, 2016, we did this meeting that we just we just finished here in Sao Paulo. We did it in Cartagena. And then in 2017, we got the Joint Commission Clinic Care Program for hydrocephalus, then again in 2020, and then in 2022, and we'll be having it soon in a year or so, recertified. So the Joint Commission International is the first clinic that is accepted by Joint Commission, or approved by Joint Commission in the world, actually. It's the Joint Commission International is the world leaders in healthcare accreditation and the author and evaluator of the most rigorous standards in quality and patient safety. If you read that, it's absolutely, we do what we were taught to do in medical school, to do things perfectly. And you do them perfectly, you can do anything in life. So these are the phases that we have in our clinic of neuropressure. That's the idea to be here, because I know Fernando is beginning or built already a clinic here. And so it's very important. I know that physiotherapists are here. I know neuropsychologists here. I know nurses are here. It's very important to do this as a group. And I'm going to show you very fast what we do. We have 5 phases. The first phase is the clinical suspicious. You have to think, what patients I am going to take to the clinic? You can just pick them up? No, you have to see they have the big ventricles. You have to see the index, Evans index, greater than 0.3, the callosal angle smaller than 90. And if you have that, and 1 or 2 of the symptoms, the triad I just said, especially the gait and incontinence, urinary incontinence, or mental problems, then you have normal pressure hydrocephalus. You think you have it, then you take it to the clinics, and we start doing the test. We hospitalize the patients for 24 hours. That's the way we do it. And we do exams. What exams we do? We have the evaluation by neuropsychologists before the lumbar puncture. Physiotherapy takes a look at the patients. And many others, also urology because of the incontinence, geriatrics. Okay, physical therapy. And then we do the lumbar puncture. I will tell you in a moment how we do the lumbar puncture. And we do tests like time up and go. That's the way they walk. And 10-meter walk. Look at this. This is for neuropsychology. This is the King's picture. Look, we put that to the patient, or they do it, and they say, copy it. Look how they copy it before the lumbar puncture. I will show you how it is after the lumbar puncture. How do we do the lumbar puncture? It's very important. This is the most important part. Use an 18-gauge needle, thick needle, and how much CSF you should take out. What is not the amount of CSF, you have to take enough CSF out to lower the pressure to 0. You have to create a gradient. If you only take 10 cc's or 20 cc's, you're not doing much. You have to create a gradient. Lower the pressure to 0. It's not, you just put the needle in and let the CSF come out slowly, slowly. Sometimes it's 30, sometimes it's 40, sometimes it's 25. It depends on every patient. Lower the pressure to 0, gauge 18. Look at this. 24 hours, you see the difference. It's not perfect, but you see the difference. Just after the lumbar puncture. I can do it here. You see this and this. See a big difference. Look. Before the lumbar puncture, time up and go. 3 meters and come back. I'm going to do it immediately. Look at the difference, 24 hours. And the time up and goes 10 meters. Look at this. Compare it to this. Only in 24 hours. And we take the time, with a stopwatch. I always put this picture here because during life, I don't know if I should say God has given me a lot of opportunities. The person you see there, with his permission, he is the doctor who taught me internal medicine. He was a person who motivated me a lot. He was very intelligent, knew a lot about internal medicine and how to look at the patient, all the signs, which is something very interesting as a medical student, that you learn those signs. When you study medicine, you love those things. At least I did, and I know everybody that's a doctor here love those things. So he was diagnosed with Parkinson's. He was in a wheelchair for 5 years. And one day someone told him, I think you have another disease. They took him to my hospital. What he really had was normal pressure hydrocephalus. We treated him, and he's doing well. He's doing very well. I don't have videos, but he's doing well. I've had many opportunities of treating people that have helped me. So now we do the VA shunt. I don't know, neurosurgeons here, how many? Two? Many people do VP shunts. We do VA shunt. I don't know if I should talk about this because this is more for a neurosurgeon, but Dr. Rigamonti was the first to describe, and this is the article. To do a VP shunt takes at least 20 minutes. I would assume to do the incision and whatever. Only 5 minutes? Then forget it. I cannot show the movie. Dr. Rigamonti was the doctor who described this technique, peel-away technique. In 5 minutes or less, you have the catheter in the right atrium with this technique. I don't have enough time to show it, but I will send it to you afterwards. So we do the VA shunt. And what we do is we lower the pressure. We measure the pressure in surgery, and we only lower it 1 centimeter of water. We don't lower it a lot because if you lower it, you can have subdural hematomas or collections. So we lower it only 1 centimeter. If it's 14, we leave it in 13. And 8 days later, we do a CT scan. And if everything's perfect, we start lowering the pressure. We never lower the pressure more than 30 centimeters of water. But I'm not going to show this because I don't have the time. But look at this. This is very nice. Before, 3 months later, 6 months later, and 12 months, a year later. We take care of them. We look at them every 3 months until they complete a year. We do the same test. I will send you this if you need it. I'm not going to specify everything now, but it's very important that neuropsychology tests. Why is it so important? And I was telling the neuropsychologist from your hospital just now. What's your name? Amila? Bueno, Amila. It's very important. Neuropsychology is so important in this disease because they can tell us if the patient has a dementia typical of normal pressure hydrocephalus, or it's also a dementia that has some signs of Alzheimer's. Because, a patient can have the two diseases. You can have normal MPH, and you can also have Alzheimer's. So you tell the family he's going to do well in the part of hydrocephalus. We can help them when you shunt him. But in the long run, the Alzheimer's is going to kick in, and is not going to do well at the long run. But at least we can help him for a couple of years. So that's the most important thing of neuropsychology, and they help us a lot. This is very important. 38% of the patients that we have treated, this hasn't been published. I thought it was published, but it hasn't been published. 38% what we have found, patients that come to our clinics that have been diagnosed with Alzheimer's, they really had is MPH, and we have been able to help them. So that's a big number if you take into account the number of patients in the world that have Alzheimer's. And 100% we have been able to help them, those patients. So that's very important. This is something that has been published 2 months ago in Nature with a new terminology in neurosurgery, where in the medical world it's pseudoatrophy. If you can see this patient here, look, this was read as atrophy, but it didn't really have atrophy. Look what happens when you shunt the patient. The atrophy disappears. So when you have a patient like that comes to your office in a wheelchair, that doesn't walk, is demented, incontinent, and you see an MRI that's red as atrophy, there's nothing to do. And if you don't know this disease, you send them to a nursing home probably because there's nothing to do. So it's very important to have this in account. This is what we've done during the last 10 years over this, all the meetings that we've been. And this is the last picture probably. This was a patient that we did all the studies. He was shunted, but after a couple of months, he started doing bad again. We took him to the hospital, and the shunt is VA, did a kinking in his chest and his heart, so he was doing very bad. Look at this. That movie was done by his daughter. That's the day he comes in the airport. He has his own plane. Look, the plane in the button. Look, 2 days afterwards. And look in January of this year. She sent it. And this one, this lady.
So.
She told me that she used to be in Colombia many years. But look at this.
Muy bien.
We did the test, we shot her.
Muy bien.
He's dancing. There's Daniel. So if you want to go far, feel like you're in honeymoon with what you do. And I know I only have like a minute, but this is a video I found of my father giving a talk. And I would like you to hear the questions that he asks the audience. It's in Spanish, but it's traduced in English. That was my father.
Quiero hacer 3 preguntas que quiero dejar más bien flotando en el aire como motivo de interés para que sigan la charla. Primera, ustedes han visto muchas personas con insuficiencia cardíaca congestiva, en que hay un aumento de la presión venosa, obviamente, el paciente se edematiza, si es hombre, el escroto baja mucho, el hígado baja varios veces debajo de la costilla, los párpados se hinchan, hasta las conjuntivas, prácticamente todos los órganos se hinchan, se edematizan, exceptuando uno, el sistema nervioso central. ¿Por qué? ¿Por qué no se edematiza? Uno ve enfermos respirando mal, con insuficiencia, sin embargo, están conscientes. Segundo, si un paciente de estos le hacen ustedes una punción lumbar y le sacan líquido en buena cantidad, ¿qué le puede pasar? Y tercera pregunta, ¿cuál es la presión del líquido cefalorraquídeo en una persona que acaba de fallecer? Esas 3 preguntas se las dejo ahí a ustedes.
You have the answers? You understood the first one? Congestive heart failure. Everything is edema. Everything, except the brain. Why? The second one, what happens if you do a lumbar puncture of a patient that has congestive heart failure with edema? What will happen? And the third one, what is the pressure, intraventricular pressure or intracranial pressure of a person that just died? So as for the next time you invite me to Brazil, I'll give you the answers. Thank you. That's all. That's all. Thank you. questions? Preguntas, questions? You don't have any questions? Nobody has any questions? No? Neuropsychology has any questions? You understood how important you are in these clinics? ¿Cómo es de importante? Muy importante. Fisioterapia, todo el mundo. Esto es un trabajo en equipo y no, it's not hard. You can do teamwork, organize yourself like Dr. Rigamonti both just told us how important it is to organize yourself, and you'll do great things, organized. Okay? Thank you.
Professor Hakim, one question here.
Hola.
João
Hola.
Luis Pinheiro Franco.
Hola.
Just one question.
Yes.
I think it's a simple one. Why did you follow your father's career?
I will tell you, it probably comes in the genes. You know what Hakim means in Arabic?
No.
Doctor.
Wow.
Hakim is the doctor. In Lebanon, in Arabic, who knows Arabic here? You know Arabic. If you say the word Hakim, it means doctor. And obviously, if I saw every day of life seeing my father, he taught me so many things in a very nice way. He taught me things without knowing. I learned things without knowing he was teaching me. And every day of my life, I remember my father, what he taught me, many things, many things. For example, he would say, you're valued by the number of friends you have. And another one, he said, there's no small enemy. No enemy is small. Be careful with that. Think that I have the life of my father also for a meeting. I could give a conference, which is very interesting because you start once in a meeting, I was told to give a talk of my father, and I started saying, where am I going to look? I mean, it doesn't really exist it was all in my brain. I just put pictures, and every time I saw a picture, I would talk, I would say a lot of things. I would talk, he taught me many things. But because probably I saw all the time, I saw my father working, and the second floor of my house was a lab where he did the shunts. So every day we would help him do the shunts, and then I liked mechanics, the cars, I like mechanics a lot, and we would be able to fix the cars, do a screw up in the lab, and I was motivated by that. Thank you for the question. Nobody had asked me that question before. No? Not really? In a meeting like this, no? I love to answer questions, but if you don't have questions, thank you.
Mais alguma pergunta? Thank you, Dr. Hakim. So now I would like to invite Dr. Fernando Gomes for his presentation. Please.
Thank you. It's an honor to me to be here with the Professor Daniel Rigamont, Karin, with the Professor Fernando Hakim. Well, we know Alzheimer, we know Parkinson, and we know Hakim. So, of course, there is a name that we put in this disease, like normal pressure hydrocephalus. But sometimes we have a little bit concern about to not, lose the opportunity to honor the people that did very nice job and your father. So Hakim syndrome is the name. So hello everyone. I would like to talk about a subject that's becoming more important every year. And I truly believe that will shape the future of the medicine. We are talking about organization of hospitals, education, very nice relationship, much more than money. We're talking about lives. The development of such kind of way of treating the patients, like institutes like here in MORIAH, probably will be the future. And the future that we need, because we are facing an aging revolution. It's true. Our challenge is helping people to live better. This is our main concern, or should be. people must live with dignity, with independence, and for sure with brain health. So let's start with this simple fact. This table shows that the world is getting older, and we know that. Every country is experiencing this transformation, and of course, Brazil is no exception. According to the United Nations, the number of people over 60 years old will grow dramatically over the next decades. But perhaps the more important is people and population growing over 80 years old. This is not a prediction. This is already happening. And our healthcare system must adapt sharply. And why this is so important for us? Because aging and neurological diseases are closely connected. As life expenses increases, we see more dementia, we see more stroke, Parkinson's diseases, tumors, falls, and PH. And of course, more patients living with chronic neurological conditions. And this affects not only the patients, it affects the families, the caregivers, the hospitals, well, and the society as a whole. And that is why they deserve our attention. And NPH is different because it's not just something about MRI, ventriculus, or CT scan. It shows up in the daily life. We know the Hakim triad, the gait disturbance, the cognitive impairment, and the urinary symptoms. But real patients, like him, from the MORIAH, they have more than a trait, or they can have more than a trait. They walk slowly and fall, they lose independence, they are embarrassed because the incontinence, the caregivers feel stressed and tired, it's reality also. And most of them also have other problems, frailty, depression, problems regarding the fear of failing, falling, diabetes, social and economic vulnerability. And so NPH taught me something that is very important. Success is not only to do a technically perfect shot. Success is when the patient regains autonomy, dignity, and mainly participation in normal life. So very soon we realized by ourselves, and of course learning with the very important teachers as Professor Daniele, as Fernando Hakim, that no single professional can handle with everything that NPH brings together. I'm a neurosurgeon, I can treat the CSF problem, but it's not enough. We need neuropsychologists, we need neurologists, we need physiotherapists, occupational therapists, speech therapists, nurse, nutritionists, anesthesiologists, sometimes music therapists, and others. And this was a turning point. So the creation of a hydrocephalus unit became a multidisciplinary brain recovery program. And we were not only treating, of course, ventricles, we are treating people, and we are treating their families. So NPH also brings something very, very closer to me in terms of innovation and industry. And we must share this for our population and for the world. This is a field where technology matters. Programmable valves allow us to individualize the pressure settings. And this is very important to treat this disease, mainly because the aging patients. In São Paulo, we have HPBio as a very nice example of local med tech developing and producing valves. We also have in our state, São Paulo, Brainful Care, that adds a new dimension of non-invasive measures of the intracranial compliance. And it's something disruptive. But the most important lesson for me is that innovation should not start from a product. It should start from a clinical problem. And we are facing this here in our country. When universities, companies, factories, clinical teams sit together around, as we do in real world with real patients, technology becomes more useful and more ethical, I'm sure. This brings me a subject that's very close to my heart, so the normal pressure hydrocephalus. I studied at the University of São Paulo. My livre docência, that's after the PhD, was in this subject. And for many years, patients were told, and I listened during my graduation, that their symptoms were a single part of the aging. So difficult walking, memory problems, urinary symptoms, but we know that many of these patients, they can improve, sometimes dramatically, as Fernando Hakim showed us. And it is why the early diagnosis is so important. In 2007, we created in the University of São Paulo, in the Hospital das Clínicas, the Cerebral Hydrodynamics Unit. And our original goal at that time was to organize the care for patients with normal pressure hydrocephalus. Because telling the truth, it was a real mess at that time. So, of course, we improved the treatment, we become very low, the rates of infection, but it's possible to say now that we create a multidisciplinary team, and to integrate it, give us an opportunity to offer better outcomes for the patients. And this experience eventually led to a creation of this NPH Institute here in MORIAH Hospital. Our vision is straightforward: to connect the clinical care with education, research, innovation, and of course network with very important centers like we are facing today. Because when these areas work together, patients benefit, and healthcare systems benefit as well. So there is also an economic impact when we have problems like a delayed diagnosis. Patients lose independence, hospitals admission increase, families face great burdens, and healthcare costs rise, and it's not good for the system, for no one. On the other hand, early diagnosis and treatment can improve outcomes while reducing long-term costs. And it's, for me, it's good medicine, it makes sense. And also, it's good healthcare management. So, one lesson we learned very early is that no neurosurgeon works alone. Recovery is a team effort. Neurologists, neuropsychologists, physiotherapists, anesthesiologists, nurses, and many others. And when everybody works together, outcomes improve. Professor Higamon showed us. And patients have the better chance to regain independence. So, answering the question, this is why a dedicated institute in NPH care here in Brazil, in the private system, matters. Thank you very much.
Obrigada, doutor Fernando. Alguém tem alguma pergunta? Bom, então antes da gente encerrar, eu queria compartilhar com vocês um vídeo do Grupo Condor, que é um apoiador desse nosso evento. Deixa eu passar.
Importar na saúde exige mais do que executar etapas, exige enxergar a operação como um todo. Com 4 décadas de atuação especializada na área da saúde, o Grupo Condor desenvolveu um modelo capaz de transformar operações complexas em estruturas controladas, previsíveis e eficientes. Por trás dessa operação, existe um time de especialistas que atua de forma integrada, trabalhando de forma coordenada para garantir segurança, conformidade e performance em cada decisão.
Gente, agora eu vou abrir para as perguntas finais, se alguém tiver alguma pergunta. If anyone has any questions or anything.
Good night. Thank you so much for all the talkings. And I'm a physiatrist, so it's very nice for me to be here and to discuss all these things. And I would like to ask Fernando, how is this program starting, and how can we send some patients, and how are all this working?
Alexandra, thank you very much for coming. Well, we have two ways. Because here in Brazil, we have the public health system, we call it SUS, and then Hospital das Clínicas, we have this program, the cerebral unit, hydrodynamic cerebral unit, and then you can send via cross or something like this. And MORIAH, we have a center, a call center here. You can just ask for the patient to call or just to say, Fernando, please see my patient, because we are trying to make something very real and very close to the patient. When I go to the Congress, Fernando and Professor Daniel Higamont knows how I think. For me, the shunt is not the shunt that they treat the patient. If I put a programmable valve, and I'm facing it right now, okay, I want to share with you, I have a patient now that's in another building, another hospital, and the valve is not so well. But if a doctor doesn't have a team or himself say hello to the telephone and run to make it even a programmation or setting the valve in a different way, we are just losing money, because the technology is to be applied. So in this way, so if you have a patient, please call me or call the hospital, and they'll tell me, and we will treat all the patients in this way.
Yes, I thank you so much, because I face this every day on the private consultation. You know that, because I send a lot of patients, and I think we are missing diagnosis a lot. So that's very important, and I appreciate all the initiative. Thank you.
Yes, I think we have a patient, a case report. See, we started about 3 months ago, something like this, and Alexandra sent me a patient. Maybe you can tell if it's true what I'm telling and how it's going on with him.
Yeah, it's very true. And his first patient of mine was my father, and I faced the same thing that I faced a lot of times after that with many patients. And this one was a very nice patient, and he went there not because of all the neurological problems. He went there facing lumbar pain. And after, when I was examining him, neurological exam, I realized that he has the gait, and I was asking all of the questions, but we face this a lot with patients, because they are aging, they have diabetes, they have neuropathic pain, they have other things that mixed with all the symptoms. So it's very difficult to do diagnose. And then I was asking him, and I saw all his exams, and he went to the otorrino, and they did MRI, and the MRI showed hydrocephalus. And I saw, did someone told you that you have this exam with a problem? He said, no. I said, okay, so I want you to see a neurosurgeon, because I think you have another problem that is not related with the lumbar pain. Lumbar back pain we will solve, but I think you have to see a neurosurgeon. Then he went, did the TAP test, and he did the shunt, and he's doing very well. So it's a lot of times we see these patients at the consultation, and we have to do more diagnosis, I think. And it's how Fernando said, because if we don't talk to each other, if we don't feel and act as a team, we'll never treat these patients.
Thank you. I'd like to make this question for Professor Daniele and also for Fernando Hakim. How do you suggest to deal with the patients in this situation? I mean, we put a programmable shunt, okay? And sometimes, mainly in the beginning, we have to do some adjustments. How is the perfect way, in your point of view, that the patient can contact the doctor, the system, or the hospital? What do you suppose? What do you think about this? You know, it's about care.
I had a very bad habit. I used to give my phone number to the patient. They never call them as absolutely better.
Yeah.
They were very respectful. If they needed a problem, they call.
Directly to...
She just said to me, you do the same thing. I always give the phone to the patients because, especially if you're a neurosurgeon, I mean, most of the patients call you, if they call you because they're worried, they have something. So that's one of the ways. And the other ways, there's always, for example, Daniel, or they have, the patients have their number and they can call them, or they can call to the emergency ward, or they can call my secretary. But there's always someone ready to answer the question.
So congratulations for the panel, very interesting. We are from Brain for Care. Brain for Care exists because of an NPH that was treated. Professor Sergio, our founder, was misdiagnosed with Parkinson's. He was 78 years of age. Took a year to understand what he really was, NPH, a physics professor. And then he said, why do I need to drill a hole in my skull to measure pressure? And he's the one that proved that the skull pulsates, and created here with Gustavo the technology, and then he invited us here to build science into a business. And as former consultants, Dr. Karin, we work a lot with changing management, and NPH, besides everything, is a very painful value chain. Very inefficient, very unorganized. The patient has to go to a lot of problems, since suspicious to diagnostic, to shunt management, and shunt dysfunction. We have a lot of stories on that. And congratulations for organizing part of the value chain here at the hospital. My question is, I think we are getting there to organize the care chain. How about the payers chain? So how are they reacting to the work that we will do, reducing the total cost of the journey? So how are they going to, how is the feedback from them to sponsor that and being the beneficial at the end of the day from an economical point of view? Do you have any feedback on that?
Yes, something very objective. We had a thesis that we did in University of São Paulo. Rodolfo is not here. He compared the fixed pressure valve with the programmable one from HPBU. And after a year, from the beginning, of course, it's more expensive to put a programmable shunt. But after 1 year, we showed that you save money. You save money, you save bad experiences for the patient, less reoperations. So yes, falls, but the matter is that the guy that buys, the decision is punctual. So say, oh, if I can buy one for 10, let's do, and it's not. So we are facing with the situation to explain and to show. And I feel when I see here people like them that have real experience, we are in a right way. Probably to treat this kind of patients with NPH, centers with a multidisciplinary team, knowing what to do and doing and following the patient is the secret. I know that you have something that you can share. We talked about it in the past, and now we have some results from the south part of our country, because we believe that we have a lot of patients with NPH that are underdiagnosed, maybe inside some homes, and of course they can have also Parkinson, also Alzheimer, but they are. And so, for example, looking for something that's not a tap or not blood exam, but something very simple, like putting the sensor for brain for care, we can do a kind of checkup in a very fast way, and then to put this patient in this a track like this. Not look for a neurologist. No, go to a specific center to see if you have or not NPH, to treat or not NPH.
Health economics person in the team.
Oh yeah.
To help with the calculations.
206.
In another way, it's more expensive not to treat a patient than to treat the patient. Definitely. If you can show the numbers, we were talking about that, doing some type of work. It's a lot more expensive not to treat the patient. And if we could use really if we have the numbers for brain for care, I mean, you have it in the trunk of your car, just put it in every patient that you think. It's very easy, and if you have the numbers, they say you have MPH, they would take them to the hospital. That we could bring a lot of, there's at least, doing the calculation, I think around the world, there are how many million? 32 million, as you show. That's a lot of people, and if there's probably even more. That's a lot of people. If we could help all those people, we do a great job. That's a job well done. So we have to work, this is teamwork. We cannot do it by ourselves. There's 2, there's 3, there's 4, there's 5, 6. That's what we need to do.
We look at Medicare data years ago and compare the cost, Medicare cost of people who had shunt surgery for hydrocephalus and people who possibly had hydrocephalus but were not shunted. And the difference was dramatic. After, again, a few months, the cost became much higher in the non-treated group. And we published that.
It's $10,000 savings per patient. The savings cost was $10,000 per patient. 10,000, and this was in the patients ending in the year 2006 for the data. Yeah, 32 million people.
Exactly, and nowadays it's a lot more expensive, probably a lot more money. And another thing that nobody takes in that we measure, I didn't say about that.
The caregiver. Yeah, the caregiver, the test SARIT, that's how we measure it. You can't imagine how it is to have a family member with normal pressure hydrocephalus. He doesn't walk, he can fall, you have to buy diapers, whatever, all those things. That's a lot of, when you shunt a patient, the quality of life in the patient is better, and the quality of life in the caregiver is also better. So that I mean, there's a lot of problems that you don't even know that are under and aside of all these patients. It's a lot of burden.
I just want to share one example. A very good friend of mine, I was telling about the cases, and I monitor him, very abnormal, and he told me, I'm having some urinary urgency, 68 years old. I referred to Dr. Alan Castro. He made the image. They started to treat first with acetalosamide, with a geriatric, didn't go well, away from our still bed, and he did the surgery last week. And he is now really better and away from 3 months, from invisible to treated. So that's another, I think, big change in the value chain, make it much faster.
Okay, thank you. I had an idea. Fernando Joaquim, you told about breast cancer, yeah? So breast cancer, yeah? So we have the Pinky October, yes. And also we have a date for hydrocephalus. It's September 12th September, yeah?
In Colombia, we have June 4th, birthday of my father.
But you know that worldwide is...
We have hydrocephalus day in Colombia is June 4th.
Yeah.
Birthday of my father, so that's the romantic, but it's nice. It's birthday.
I mean, we could use this date, worldwide to make some noise because the numbers are huge and aging process is dramatically high.
This is the first time that I come to a meeting that tomorrow, when I go back to Colombia in the place, I'm satisfied because I feel that more people are getting acquainted that this disease exists. We can help a lot more.
Thank you. Thank you so much.
So thank you. I'm gonna end this meeting. So thank you all for coming for the summit. Thank you, Dr. Higamonte, Dr. Karen Higamonte, and Dr. Fernando Hakim, Dr. Fernando Gomes. Thank you. Have a safe trip home.